case of insomnia. A patient is a 52-year-old woman referred from her gynecologist for assessment and management of depression and insomnia. She began receiving hormone replacement therapy 6 months ago and has experienced a decrease in perimenopausal symptoms of hot flashes, night sweats, and foggy brain. She remains on sertraline 75 milligrams a day, which she tolerates well. The hormone replacement therapy helped some with her emotions, but she still often feels sad and worthless and remains tired during the day due to trouble falling and staying asleep. She is otherwise healthy except her BMI is 32. A recent EKG and labs are within normal limits. In your evaluation of the patient's insomnia, which sleep disorders are you most likely to consider and assess further? Choose 2. Hypersomnia disorder, insomnia disorder, narcolepsy, obstructive sleep apnea, hypopnea disorder, sleep-wake fatigue disorder. Given your diagnostic suspicions of likely sleep disorders, how would you most relevantly assess the patient? Choose 3. Obtain a history of sleep, nighttime and daytime symptoms. Obtain a medication and substance use history. Order a brain MRI. Order a chest x-ray. Order a polysomnographic study. On evaluation, the patient is found not to have obstructive sleep apnea or hypopnea, but to meet criteria for insomnia disorder with sleep onset and maintenance insomnia. Which treatment interventions are you most likely to start with to address the patient's insomnia? Choose 2. CBT, CBTI, doxepin, sleep hygiene strategies, or temazepam. The patient agrees to start CBTI for her insomnia, however her adherence and motivation are moderate to low. She says she is overwhelmed with work and responsibilities and that her depression interferes with her motivation. She asks for a sleep medication and to consider returning to CBTI later. Which medications would be most appropriate? Daridorexant, azopiclone, Ramelteon, Zolpidem, Zolpidem. Choose 3. The patient's sleep is substantially improved with the hypnotic agent you prescribed, and she is tolerating it well. She complains, however, that she remains sad, has poor self-esteem, and is tired every day. What is your most likely next step? Choose 1. Switch sertraline to venlafaxine XR, switch sertraline to mirtazapine, augment sertraline with cariprazine, augment sertraline with lithium, increase the sertraline dose. All right, so given what we know, the most likely diagnoses are going to be insomnia disorder, but also, she has a BMI of 32. We don't really know much about her, problems with sleep, so we at least really have to keep behind this index of suspicious for obstructive sleep apnea. And what are we going to do? We're going to obviously obtain a good history, including of sleep, nighttime, daytime symptoms, medication, and substance use. And then if we are indeed considering obstructive sleep apnea, we're going to order a polysomnographic study. Given what we know, we're definitely going to pick CBTI, and, I think another option is sleep hygiene strategies, and usually we don't want to do that alone or stop there. But again, if we want to lead a patient, forward, we can start with that, see how they take to that, see what kind of improvement, and then the sleep hygiene strategies are going to be a part of CBTI. It's a component of it, and then it's easy to transition a patient without any loss of time or effort or misdirection to CBTI. I mean, CBT in itself is really, not going to be addressing her insomnia. It's certainly, she could benefit from CBT because she still is rather depressed. So she agrees to CBTI, but she's just not able to kind of be motivated. So if there was an option for motivational enhancement, I would think that. But this is common life. She's just overwhelmed. She's depressed. While all of these, there's a time suck. It's very common for our patients say, psychotherapy, are you nuts? I mean, I don't have time to tie my shoes and, use the bathroom, and you want me to, no way. So, our two antidepressants here, are going to be bidirectional and azopiclone for sleep onset and sleep maintenance indications, unlike the other three. So those are going to be two choices. If I'm given two choices, those are the ones I'm going to choose. And then this one, obviously anything might work, but she's only on 75 milligrams of sertraline, and she has benefit from it. So she's just really on too low of a dose. So the simple thing, get her up to 100 at that visit, and, they'll review it later. And then everything else is open if she doesn't respond further. Falling asleep. A 27-year-old man is referred from primary care for evaluation after he was involved in a single motor vehicle accident. He states he must have fallen asleep at the wheel. Falling asleep while driving has happened to him before, but only when stopped at red lights, and he hasn't had previous MVAs. He states that his sleep has always been messed up, but now he's even more tired today because of his hectic work and part-time school schedule. He denies alcohol and other drug use. His referral note from primary care noted that his physical exam is normal and routine blood work is normal and within normal limits. Given your diagnostic suspicions, which other symptoms would you anticipate would be present and that you would carefully evaluate for? Sleep paralysis, excessive daytime sleepiness, hypnagogic hallucinations, insomnia, snoring. What are the most specific sleep studies to obtain to confirm your diagnostic suspicion? CSF measures of hypocretin 1 levels, dissociative experiences scale, a FLAIR MRI of the brain, multiple sleep latency test, or polysomnography, and you're asked to choose 3. The patient is accompanied to the clinic by his girlfriend. She describes the patient's episodes of facial droop, slumping over, and even falling over. The patient concurs, stating that his loss of muscle tone is precipitated by laughing, like at a joke. What is the term for this series of manifestations? Choose one. Is it catalepsy, cataplexy, Gegenhalten paratonia, or paroxysmal parasomnia? You diagnose the patient with narcolepsy, with cataplexy, or hypocretin deficiency type 1. Which medications will most effectively target the patient's excessive daytime sleepiness? Choose 3. Bremelanotide, modafinil, pitolisant, suvorexant, solriamfetol. Choose 3. Your other goal in treating your patient for narcolepsy is to target cataplexy, that is, to reduce REM sleep intrusion into wakefulness. Which of the following medications are most likely to benefit this aspect of the patient's disorder? Choose 3. Flibanserin, methylphenidate, pitolisant, sertraline, sodium oxybate. All right, so given your suspicion, right, you're probably thinking narcolepsy, so the ones that are most directly related are going to be the first 3, although insomnia certainly is going to be a common one too. So that's kind of why I put that in there, because it's sort of like sometimes you're like, well, hold on, I want to pick 4, but you're not given the options. So then kind of like, well, what do you do? Then pick the ones that seem to be most kind of the questions directing you towards. What are the most specific sleep studies to obtain to confirm your diagnostic suspicion? The CSF measures of hypocretin 1 level, multiple sleep latency tests, and polysomnography. This series of manifestations, these phenomena, that's cataplexy. Remember that catalepsy is a symptom or a sign of catatonia. Remember, a cat leaping, cataleaping. So cataplexy is falling down. Cataleaping is that kind of like that stop motion where, you're kind of like are in a weird position and you're kind of holding it against gravity, and then you can kind of come in and move that person because they got that waxy flexibility. Paroxysmal parasomnia, I just made that up. And then, so the patient is, let's say, confirmed with narcolepsy, and we're focusing specifically now on excessive daytime sleepiness. So we're going to do modafinil, pitolisant, and solriamfetol, because those are wakefulness, increasing medications. Bremelanotide, that's for hyposexual arousal disorder, whatever it's called, I forgot right now. And then suvorexant is the orexin antagonist, which is like the last thing we want to do, because we don't want to, remember orexin or hypocretin, this is part of the wakefulness producing system. We don't want to antagonize it, so that's the last thing. I could ask this question, like which one of these is the most highly contraindicated? And then which of these medications will target cataplexy, and they're going to be pitolisant, sertraline, or any other SSRI, sodium oxybate. They're not going to be flibanserin for sure, and they're not going to be methylphenidate. Now, it's not to say that these SSRIs are, like fully effective, but they do often help, even if it takes like higher doses.